Today's webinar is proudly being hosted by the Brain and Mind Institute at the Aga Khan University in partnership with Dixon Chimbanda and the University of Zimbabwe. We're very proud and happy to be partnering with Lancet and the World Psychiatric Association to host the African launch of the Lancet Commission on Depression. This is a monumental report. It's proving to be highly impactful in shining a floodlight on depression, a brain health condition that carries the largest burden of illness worldwide. Depression and related mental health issues are of high relevance to Africa for several reasons that we'll be discussing shortly. But one of the unique realities of Africa is that it is the youngest continent in the world, with half its population being under the age of 19 years. This means that Africa is poised for tremendous economic growth and global impact. However, the realization of this potential may be threatened by certain important factors, such as climate change and depression. In terms of the impact of climate change, the lessons learned is that we have passed the point of prevention and promotion. The horses have already bolted. So now we are focused mainly on mitigation strategies. In contrast, in the case of depression, we can not only mitigate its impact through treatments, but we still have the opportunity to promote change and to prevent depression. Depression typically manifests in the youth years and can negatively impact the educational trajectory, productivity, and health. In other words, it can impact Africa's future human capital. Depression and related mental health conditions are also highly relevant to the mission and vision of the Brain and Mind Institute. So our mission, our focus is on mental health and on brain health. And our vision is healthy brains, healthy world. We're focused primarily on three main domains of research, focused on depression and anxiety, stress and trauma, and suicide prevention research, which are, of course, three overlapping domains of high relevance to the discussion of the topic on the Lancet Commission report. Recently, we developed an integrated mental health framework because in the geographies that we serve, the reality is that we cannot use the traditional approaches effectively that are launched in North America and in Europe. That is, with a focus on severe mental illness, because we don't have the specialized services or facilities available. We're trying to turn the paradigm upside down, in essence, to focus on the bottom of the pyramid, which is the largest sector of the population, which is well population, and where we can do promotion and prevention, self-care and education. And then we're focusing on people who are at risk for early identification and community level care. And then we move to mild and moderate illnesses where we can actually provide services right in the community using the resources that are available to us. And so the paradigm is a little bit different. And we are trying to achieve our objectives by addressing four major domains: research, innovation, translation, that is bringing research to care, education, and engagement. The Brain and Mind Institute currently has two main areas, two hubs, one in Nairobi that serves East Africa, Kenya, Uganda, Tanzania, and one in Karachi, Pakistan, that serves South and Central Asia. Our basic tenet is to build a tent, not an ivory tower. There is an old African adage that if you want to go fast, you go alone, but if you want to go far, you go together. So hence this concept of building a tent, a collaboration across the continent that's in our DNA. So with that, I would now like to introduce two esteemed panelists from Kenya. First, let me introduce Vivian Gaiko, Vivian is a mental health activist with lived experience and is the founder of Empower Mama Foundation, which is focused on perinatal mental health support. Next, I would like to introduce Dr. Lukoy Atwali, the Dean of Medical College at Aga Khan University, East Africa, a professor of psychiatry, a leader in the field, a prolific researcher, and a mentor. And he's also the Associate Director of the Brain and Mind Institute, a true friend and colleague. Welcome, Dr. Atwali. And now I'd like to introduce Dr. Dixon Chambanda. As stated earlier, this webinar is hosted in partnership with Dr. Dixon Chambanda from the University of Zimbabwe. Dr. Chambanda is also the African Lancet WPA Commissioner, and he is also the inventor of the Friendship Bench, an intervention that has transformed our treatment approaches globally. Welcome, or karibu sana, as we say in Kenya, Dr. Dixon Chambanda. May I invite you to share your perspective, and then you can introduce your fellow Lancet WPA commissioners, and then who will share their perspectives. Welcome, Dr. Chambanda.
Thank you very much. I am honored to be invited and to be given this opportunity to share some of the views from the commissioners. You know, as you all know, the commissioner's report is quite extensive, but some of the four major sort of recommendations include how we can reduce the burden of depression, you know, and the commissioners believe that this requires action by diverse stakeholders, largely four groups, and those four groups include, you know, the general community, healthcare practitioners, researchers, and decision makers. I would just like for us to understand, when we think of Africa, Africa is rich and diverse, and we have a lot of resources, particularly at community level. And that's one of the things that we need to start thinking about in terms of thinking outside the box, how we can really address or narrow the care gap for depression. I would also like to just take this opportunity to introduce my two colleagues who are going to be talking to you shortly. Firstly, it's Dr. Miriam Sapin from the Lancet, the executive editor from the Lancet. She has also worked as the accountability manager at the Partnership for Maternal, Newborn, and Child Health, hosted by the World Health Organization in Geneva. She has also held positions in the WHO HIV department, UNAIDS, and the Global Fund, and served as an editorial board member for the Bulletin of the World Health Organization. She has also been a disease detective in the US CDC Epidemiologic Intelligence Services, and was a senior research scientist officer in the Division of Viral Hepatitis and the Division of Global HIV/AIDS. Welcome, Miriam. And I also would like to introduce Dr. Afzal Javid, who is the president of the World Psychiatric Association. He graduated from King Edward Medical College, Lahore in Pakistan, and received higher specialized training in psychiatry from Pakistan and UK from the Royal Edinburgh Hospital and University of Edinburgh and Institute of Psychiatry and Maudsley Hospital, London. He has served the UK Royal College of Psychiatrists as Deputy and Associate Registrar Member Board of International Affairs of the College, Chairman of West Midlands Division of the College, and one of the lead college office bearers for SAS doctors and patient and carers groups. Welcome to both of you, and I am sure that Dr. Afzal Javid is also carefully watching the cricket because Pakistan is in the final. Now, over to you.
Thank you very much. It's really an honor to be with all of you here today. I'm speaking from New York City, but feeling very, very, very close to Nairobi right now. First thing I want to say, in in addition to the fact that I'm a Lancet editor, is that I'm also a person with lived experience of depression. And I say this because it's very important for us to continually reduce stigma whenever we can. It really helps. And so with that, I would like to just put the commission in perspective a bit, and why at the Lancet we find it so important to engage in this topic. And part of that is that 1 billion people globally are estimated to be living with a mental disorder, 81% of whom live in low-income and middle-income countries. Among those 1 billion, 5% of adults have depression, and that makes it the leading cause of disability, as you've heard, and a major contributor to the overall global burden of disease. By stark contrast, however, countries spend less than 2% of their health budgets on mental health on average. And when we think about health budgets, those are tiny, tiny proportions of the overall budgets. If we think about security budgets and so forth, it's really just a drop in the bucket when we look at the money that is available. So as such, the World Health Organization actually recently called on member states to please redouble their efforts to address care and financing for depression. But why are there such insufficient and inequitable health resources for depression? What can we do about it? So this is where we thought the Lancet Commission would be very helpful in addressing this, and to look multi-sectorally across various different sectors in order to address this problem. So the Commission addresses this through economics, epidemiology, neuroscience, primary care, psychiatry, psychology, public health, and importantly, those with lived experience of depression, who help to inform and positively reframe the discourse around this condition. The Commission calls for concerted action to reduce the burden of depression, as you heard from Dr. Dixon, among 4 sets of actors: scientists and researchers, policymakers, healthcare workers, and civil society. So although depression is a common part of the human experience across the life course, and I want to underscore that, there are several reasons why it does not receive sufficient resources and global attention. And the Commission points out these reasons. First, depression, as with mental health conditions in general, have historically been stigmatized. Its biological origins were poorly understood until the 20th century as new treatments became available, yet stigma, inhumane treatments, forced institutionalization still persist, despite advances in knowledge about the causes of depression and the existence of effective therapies, some of which you've heard have ignited the entire imagination of the world, like the Friendship Bench has. Second, managing depression is not always straightforward. For clinicians, family members, and those living with depression, the heterogeneous signs and symptoms can be challenging sometimes to be addressed, particularly early on. In countries without mental health insurance schemes or universal health coverage, getting help for depression early becomes a real barrier for people who are concerned about paying out of their pockets for what is a basic health human right. And depression depends on a combination of biological, social, and psychological factors. And so it also requires domestic policy and investment across sectors, such as health, education, employment, and social services. So therefore, the Commission calls on the scientific community to adopt this multidimensional approach and collaborative research needed to inform preventive care. The Commission also emphasizes the importance of detecting and diagnosing depression early, which is for good access to healthcare. And we must also ensure culturally appropriate care and therapy, and ensure evidence for low or even no cost interventions, which do exist. So in sum, the Commission lays out a stark choice to improve equitable and stigma-free access to interventions for people with depression, or continue to condone indifference to the well-being of the 1 billion people with mental health needs. So I look forward to our discussion today, and thank you very much.
Good afternoon and good evening. Dear colleagues, friends, ladies and gentlemen, this is a big day, not only for mental health and psychiatry, but also for health and for public health. This particularly joint effort and collaboration between WPA and Lancet, and then now this African launch facilitated by our local organizers, is an important step in understanding mental health and its impact. Depression, as it has been mentioned, a very important mental disorder, mental difficulty, and mental illness. And why WPA and Lancet agreed to launch this joint commission? Many reasons. Number one, depression is the most common mental health problem. Depression is the principal cause of suffering. Depression is seldom recognized or understood. And depression that remains unrecognized leads to a number of personal, health, and social difficulties. So this even makes it more important that WPA, as a professional organization of psychiatrists, and Lancet, at the forerunner of the scientific journals, should highlight this particular report. It is indeed an honor for WPA to be a part of this initiative. WPA believes no health without mental health. And within the mental health perspectives, no mental health without understanding and recognizing depression, its impacts, and its consequences. We are mindful about the limited resources in many low and middle income countries. But the most significant tool in our hands is the promotion, is the prevention and sensitizing not only mental health professionals, but also non-mental health professionals, as well as general public in this important field. We believe there are 3 ingredients of good health service. It should be acceptable, it should be affordable, and it should be acceptable, affordable, and acceptable in the sense that people recognize it, understand, and also try to get full support when it is needed. We hope that this particular launch, and with special thanks to the local organizers, we are fully confident that we will be able to take this message to the entire African region, to our health professionals, and more importantly, to our policymakers. Because despite having 25 to 30% of disability or difficulties related to mental health all over the population, the resources that are given for mental health services are non-sufficient. So thanks again. Thanks to Lancet. Thanks to our local organizer. And we look forward listening to the panelists. And we hope that this will certainly help us in fighting against the stigma, fighting against depression, and supporting our patients and their families. Thank you very much.
Thank you very much, commissioners, for your perspective and It was very enlightening and certainly highlights why this report is so critically important at this juncture in time. I would now like to kind of move into the panel discussion. And I would like to start with Vivian Geico. She, as you know, has lived experience and is been running an organization called Empower Mama. So as the majority of Africa is made up of young people, 19 years and under, they are at particular risk of experiencing depression. Particularly vulnerable are young women and moms. So Ms. Geico, are you able to speak to the impact of depression from the perspective of a young woman in Africa?
Thank you very much, Dr. Zul. Good morning, good afternoon, good evening from wherever you are tuning into this webinar from. My name is Vivian Geico, and young people, especially young women and young mothers, are at risk of depression because of various things that occur. This is a group that is of the reproductive age, and when it comes to parenthood, that is another aspect that might predispose them to depression if they go through this experience unsupported, or if there are other social factors. And given this, I'll be sharing my lived experience and what led me to start Empower Mama to support other families and other parents. As a young African woman, we are raised to value families, raising a family, having children, and I was blessed to have my first child in 2014, but unfortunately I lost a baby 2 weeks after birth, and that was grief. I grieved, but then being an issue, a social issue that is rarely addressed, or people tend to look away. You are young, you will get other children. I happened to postpone my grief, and given the other factors that were also surrounding that, my education, career, financial situation, it threw me into a deep. And before I knew it, I was going through depression. And unfortunately, I didn't know it until like 2 years later. After following the loss of my daughter, I wasn't supported. It's unfortunate. After the burial, everybody leaves, and you are supposed to get on with life as if nothing happened. And that was my situation. I kept quiet about it. I didn't know anybody else who had gone through something like that. And I was in a deep. And unfortunately, within my neighborhood, another lady who had, lost her twins happened to die by suicide. And that for me was my wake-up call, because I had also been through that situation as well. Attempted suicide, suicidal ideations, and I had never talked about it. And that is how I decided to start an organization to support people like me, people who are going through a situation like me. Was there anybody out there who understood how this journey is and how it predisposes somebody to mental health issues like depression, especially when it is unsupported? We say grief is a normal reaction to loss, but then there are other things like there's a very thin line between grief and depression. And if somebody is unsupported, they might tip over to the other side of depression, which is not healthy. And if not supported, it poses a great risk, not only to that individual, but to their family, their caregivers, and the society at large. You find people are not being productive anymore. They don't engage in activities they used to anymore. Concentrating in things that they used to do. In my experience, I concentration was a bit hard. I love reading, but I would find myself being on the same page today, tomorrow, 1 week later. And I at that point, I didn't understand what was going on, being an educated person and you're going on through all these things and then not knowing what it is you're also going through. That was a light bulb moment when I came to understand that 3 years later, that's when I really was able to connect the dots on what I was really going through. And in the African context, we rarely talk about depression and other mental health challenges that people go through. And this mainly is because it's unseen. It's not like a broken limb that somebody can see you're limping, that or somebody is having asthma, and with depression and other mental health conditions, they're unseen and people are not able to pinpoint exactly what is going on. In some situations, some people might be mistaken for either seeking attention or just being stubborn or just not wanting to participate in activities anymore. Like in my case, I isolated myself. I never used to go to any family gatherings. I totally isolated myself, and which is not a good thing. And I'm sure from the recommendations from the commission, we will see all that and on how, as individuals, as communities, we can participate in mitigating depression. Thank you very much, Dr. Zul. I will address any questions, I believe, towards the end of the session.
Vivian, I think, first of all, we'd like to commend you for sharing your experiences so openly. And it is, as Dr. Sabin was also reflecting, if we don't share our stories, it's very hard to get the momentum that we need so that people recognize this issue for what it is. Getting up so early in the morning and participating in this talks to your tenacity and your drive to make change happen. So thank you very much for sharing your journey and your story. And we will get back later on in today's panel discussion about what your foundation actually does and how you're trying to help those that have gone through a journey similar to yours. So thank you very much. I would now like to move on to Dr. Dixon Chimbanda. In Africa, over 85% of the population impacted by depression seem to go untreated due to stigma and poor access to care. Because of cultural and social norms, we in Africa often tend to seek help in unique places and in unique modalities of care. So I wanted to ask you, what are the unique ways and places where people go to seek help for mental health in Africa? What is your assessment?
Thank you. Maybe let me tell you a very short story. Years back, when I was working as a consultant for the WHO, I was consulted to go to Benin, to a place called Ouida, where together with a group of experts from the continent, we gathered in Ouida to try and formulate issues around how best to treat people in Africa, how best to address the human rights of people living with various mental health issues on the continent. We worked from this compound, from the WHO compound, which was a protected place. But outside of this protected compound was a completely different lifestyle. Some of you may know that Ouida is considered to be the capital city of voodoo, the practice of voodoo. And curious, as a young psychiatrist, at the time, I decided I needed to find out what was happening outside the walls of this compound. And I gathered confidence after a couple of days, and I went out to visit a voodoo priestess to observe what was happening within the confines of this compound. And I saw a number of people being brought in with different neuropsychiatric conditions. But one particular case, a young woman was brought in with what appeared to me from observation and the history I had received, postnatal depression. But what struck me about that interaction between the voodoo priestess and this young woman was how using language, using both nonverbal communication and using some cultural, contextual language, this priestess managed to reach this young woman who had been isolating herself, not talking to anyone, and she started to communicate. For me, that was an example of culture playing a positive role in the treatment of someone who was possibly suffering from a psychological situation. So how does culture come in? It's taken decades. We're still struggling, actually, to accept that African culture can contribute towards healing, in many different forms. In psychiatry, it's only recently we have begun to acknowledge through the work of the likes of Oye Goreje, who actually, unfortunately, is retiring. I just heard last week that Oye Goreje is retiring last week. Professor Oye Goreje from Nigeria has done some of the most amazing work around traditional healers in Africa, showing that traditional healers can actually contribute to the healing process. And this is not just simple research work. These are rigorous, randomized, controlled trials, some of them double-blinded, where he actually shows that there's a place for traditional healers. So what I'm really trying to get to is that we need a paradigm shift in the way we think about African culture and the contribution that African culture can make to the treatment of not only depression, but a wide range of conditions that we are struggling with. We have embraced the Western model and rejected our own models and frameworks of therapy. We need to be researching those frameworks as well. Yes, it has to be rigorous research, because that's what will help us to understand how best to treat people. I see the screen has changed, which means I've spoken for too long. But in a nutshell, that's what I would like to say about culture. Culture is very important. Thank you.
Thank you very much, Dr. Chimanda, for shedding some light on this. And later on during the panel, if you have a bit more time, maybe we might also address what the role houses of worship play in the African continent, where religion is very prominent in people's well-being. So we'll talk about that after, but let's move on to Professor Lukoy Atwali. There is a huge gap in mental health research in Africa. We know that there are very few publications coming out. So what are your thoughts on what kinds of research we should be conducting in Africa?
Thank you very much, Zul. I'll pick up from where Dixon has left off. There are many things happening on the continent, and there are many things that we think have positive impacts on people, healthy people and people with mental ill health. And we haven't invested enough in researching, in figuring out if they work and figuring out how they work and figuring out for whom they would be useful. So I think that is an area that we haven't done enough, and we need to spend a little bit of resources and thinking around what works on the continent and what doesn't work. But still, so very few years ago, maybe 50, 60, 70 years ago, there are many in the scientific world who didn't think that an African had the capacity to develop depression. And papers were written to that effect that, you know, because of how underdeveloped our brains are, they're not capable of experiencing depression. This was considered to be science, but it was flawed science because research was not carried out on the continent to look for depression. And the people who were making these claims were not looking for depression among Africans. And so they couldn't make such claims. Today, we still use a lot of the data, epidemiological data, large-scale epidemiological data that has been from research that has been carried out elsewhere and not on the continent. Very few African countries have done national surveys to look at the burden of mental disorders in the community. We have a survey from South Africa and a survey from Nigeria and other small studies from within countries from which we extrapolate data on things such as depression. So I think there's still room for us to spend some resources figuring out the burden and distribution of mental conditions, including depression. We also need to spend a little bit of resources figuring out service use. Where do people go when they have depression? And so we have a lot of, you could argue, an anecdotal evidence and small-scale studies that have looked at pathways to care that suggest that people go to traditional healers, people go to religious leaders, people go to community opinion leaders when they have problems. And we need to study this a little more and figure out what proportions of people go where and what are the kinds of outcomes in those places and what can we pick from those interventions that can then become mainstream interventions. The other thing that we need to do a little bit more work on is the economic burden as well as economic benefits of treatment or of prevention of depression. I don't think we've done enough. There are now efforts at doing this, but we haven't done as much as we could. Importantly, in my view, we need to think a little bit more about promotion and prevention strategies that work. So we make very sweeping statements like, you know, a balanced diet is good for you. Taking care of children prevents mental illness in future. But very few of us have cohorts of young people that we are tracking over periods of time to figure out whether the things we say are useful, are just feel-good things, or whether they actually have an impact in reducing the risk of depression in later life or not. So even funding agencies have to start having longer horizons than the 3 or 5 year grants that they give people to do this kind of work on the continent. And finally, we need to do a little bit more thinking about local examples of interventions that work across the management spectrum, from prevention to promotion to early detection to treatment. What are the things that people on the African continent are doing around that spectrum that are working? And I think we haven't done enough of that. So those to me constitute research priorities for the continent and areas where we can invest a little bit more in treatment. And finally, thinking about the concept of personalized care, because this is going to become what everybody will have to do. In a world that we are rapidly mixing in, it is going to be impossible for you to even say that this intervention works in an African setting, because an African setting is going to become more and more cosmopolitan with time. And sometimes some African settings are going to look like some American settings, and they're going to look like some Asian settings because of how populations are moving and how people are intermixing. And therefore, we're going to have to start thinking about personal context rather than larger scale community context. And where does this person fit in his or her community, and how can they be best supported in their journey towards care? So those are some of the priorities that I think we need to start thinking about. Thank you.
Thank you very much, Professor Lukoye. One of the things that, reflecting on what you just discussed, was a recent document that was launched by the government of Kenya talking about case for investment for mental health. I think that was a very forward-thinking philosophy that Kenya is adopting. Any quick word before I move on to the next question?
Yeah, so it is absolutely important that so the Kenya government made mental ill health a priority for interventions for the government up to this year. And I'm hoping that the next government that has just been elected will pick up this challenge and continue. And as part of the interventions, we have done a study on investment case for mental health in Kenya. Many stakeholders were involved. International organizations, national lobbies were all engaged to figure out what does it take to start tackling the burden of mental ill health. And they've produced a publication that starts a conversation around what investments need to be made. And the next step then is for the decision makers to start implementing these documents that have been produced as a result of this priority setting. So I think it is a good beginning. I think it is something other African countries need to emulate. And if we start there, then hopefully we are going to make a dent on the burden of depression on the continent.
Thank you very much, Dr. Lukoy. Now we move on to Dr. Miriam Sabin. Most of the scientific publications, hence scientific evidence on mental health, comes from North America and Europe. There is very few scientific publications coming from Africa. In a commentary on mental health in Africa, Osman Sakosh and colleagues stated that the Lancet Global Health has made a good start in addressing the physical health problems facing African people. It is now time to turn to mental health challenges. So as an executive editor for one of the most influential journals, what are your thoughts on how can scientific journals help so-called level the playing field so that much needed mental health data from the developing countries get published and serve to inform the global field?
Yes, absolutely. And I'm glad that you are asking this question because it is not just about what individual researchers do or what is funded, but journals are in some ways gatekeepers or can become gatekeepers of knowledge, which is not what is needed. And we have seen a lot of improvements in this area, but so much more needs to be done. If we look across the needs to really decolonize scholarly publishing. So some of the things that we are doing is, and not just the Lancet, but other major journals, has been to increase the journal content on mental health or places where mental health studies can be published right off the bat. So if the Lancet, for example, you have the Lancet weekly publication, we have a Lancet psychiatry publication also, which people may not know about. We also have Lancet child and adolescent health. And there that can also target studies that are looking specific to the child and adolescent health population. And of course, also Lancet global health. And as I said, other journals also have these. One very heartening piece of news is also that there are more journals now in Africa for the African audience. And that's extremely important because sometimes people just, select themselves out of the process of even sending a manuscript to a place like the Lancet. They may think, well, maybe it'll never get published, or it's not a randomized controlled trial, or English isn't my first language, or they're not going to be interested in this. There's so many reasons why we do this as humans in general, that it's very important to have various levels and types of journals that can target these kinds of publications. And just because it's not in the Lancet doesn't mean it's not incredibly important and isn't going to inform the dialogue. But as I go back to say, there are many things that Lancet can do and others to reduce the barriers. Some of the other concrete things that we have done is we have a mentorship program for researchers who would like to be on our editorial boards. And we do have Africans from, I believe it's 4 or 5 countries who have gone through that process and have been on editorial boards. We have the kinds of opportunities that, Dr. Dixon has been able to do on Lancet commissions, where commissions recognize the important work that's being done, that's coming out of Africa, and the absolute, essential nature of incorporating all regions in such publications. One thing that the Lancet does is, and not all journals do this, and I think they should, if we see many publications, as you mentioned, come from, say, North America, come from the US. Sometimes those publications are about studies that were done in African countries. We, as the Lancet, will not accept any manuscript to look at if there are not African authors on those publications that are, looking at African populations and African studies. Another really important piece of this is authorship. We see still, unfortunately, many Western or high-income authors who think that it's okay to publish their paper without including their local authors or the Ministry of Health on it. So how do they think they're going to be able to achieve the goals that they're talking about in their results? That's not going to happen. So if we want to see impact, we must ensure that authors are incorporated from local settings. And the really important piece of this, I would say, in final, which is not specific to journals per se, are the donors. Because donors are the ones giving money or not giving money to these important research questions, some of which we have heard today need to be addressed. That is incredibly important. And they also need to reduce the silos on how they provide their funding. So these are just some points, and I look forward to discussing further. Thank you.
Thank you, Dr. Sabine, for sharing your views and taking the lead at Lancet for addressing some of these critical issues. I think it'll have a big impact down the road. So we really appreciate that. I would now like to move on to Dr. Afzal Javed. Mental health care is a human rights issue. Ideally, we would like to see everyone in need of professional care get access to professionals, such as psychiatrists. However, in Africa, we have very few psychiatrists available. Many of the continent's most highly trained mental health professionals, unfortunately, migrate outside of Africa. The result, sadly, makes global inequities in access to mental health worse. So can you share your reflections on how to address or mitigate this reality in Africa and other developing countries?
Well, thank you very much. I think you are absolutely right that there is not enough psychiatrists all over the globe. In some countries, even one psychiatrist per 1 million population. Unfortunately, we are not going to be at that position that we will have enough psychiatrists. So World Psychiatric Association believes that to provide and to support the mental health services, we should try to train people not only who are going to become psychiatrists, but also emphasize on the importance of teaching and training for health professionals. I'll give you one example, medical students. If you look at a class of a medical student that graduate from a medical school or medical college, hardly 2 or 3% of that group will become psychiatrists. So what happens with the 95, 96% of those graduates? If they are not provided or sensitized about mental health, how would you imagine that in their roles as physicians, surgeons, they will be able to identify or speak for mental health? So this is one important aspect that we should sensitize our medical students. Same time, looking at psychologists, social workers, occupational therapists, there is a need that we promote the inclusion of mental health, disabilities, and how to approach these disabilities when we are talking to psychology, social work, occupational therapists, or even health visitors. The third thing, which is even more important, that we need to publicize and promote mental health needs among the patients and the carers and the families. Because until and unless we do not take these groups on our side, we will not be able to influence or impact the future provision of health services. And last but not the least, the policymakers. Unfortunately, we professionals are not very fluent in convincing the policymakers in their own language. When we go to them, we say that, look, we need more psychiatrists. The simple answer is, why can't we have more physicians? Why can't we have more surgeons? I think what we have to tell them, that look at the disability of mental illness, look at the impact of mental illness, and then give mental health its share, not by perception, but by evidence. There are a number of studies in many countries that have shown you spend $1 in preventing or promotion of good mental health, you will save $10 or $20 in treating those people. So I think these are the ways that we have to really follow. And I and WPA believes mental health should be practiced and perceived as public mental health. Until and unless we are not going to target those specific areas, we may not be able to achieve, we will never be able to fulfill the total number of psychiatrists. But let's try to take other professionals on our side. GPs, primary care physicians, local healers, health visitors, nurses. These are the important pillars for our promotional efforts. And we must follow the public health processes and procedures to make mental health as an important aspect. So let's hope that as time goes on, now especially with this webinar, we will be having more exposure about sensitizing a number of professional colleagues, non-professional colleagues, about the importance of depression, why to treat it, why to prevent it, and how to treat it.
Very profound reflections. And I think, obviously, you put a lot of thought into this, and this is an area that is of global concern to find out like how we can really do this. So thank you for your reflections. I would now like to move on to Dr. Dixon Chimbanda. As a follow-up to our earlier discussion about access to psychiatrists, you have in the past introduced innovations that provides alternate pathways for mental health support. What might you see in horizon for democratizing access to healthcare within the continent?
Yeah, we need to tap into the resources that are available in African communities. The work that I do, for instance, with grandmothers is an example. I'm not saying everybody should be training grandmothers, but we have managed to show that you can equip grandmothers in an African community with the basics of cognitive behavioral therapy and go on to significantly reduce the burden of care in communities. And this work is published in the Journal of the American Medical Association, where we showed that this worked through a cluster randomized controlled trial. So going back to what I had said earlier on, we need to think outside the box. Unfortunately, often as Africans, we come from a position of need as opposed to coming from a position of what do we have in our communities that we can leverage to address this particular challenge. This thinking that we have to constantly and always emulate frameworks and models developed in the North needs to change. Yes, we can learn from the North, but we equally need to tap into our own local resources that have not been tapped into yet. Thank you.
Thank you very much. And I couldn't agree with you more. Recently, we have started a trial in northern Pakistan, for example, where we're using a community resource, which is lady health workers, who actually are peers. They go door to door, and at the doorstep, we provide a tablet application app that can help them assess the mental well-being at the doorstep, but also provide some care at the doorstep. And I think that we're getting very exciting results from that. But I think, yes, you're right. We need to figure out what we can mobilize in our communities and what works and what is culturally acceptable and sensitive approaches that can be taken up by the communities that we are trying to help. So thank you for that. I would now like to go back to Vivian Geico. Your foundation, Vivian, Empower Mama, aims to deal with depression in young women to mitigate impact on young babies, and this is truly commendable. Can you tell us about what are the gaps and challenges that you're trying to address in these vulnerable groups of mamas and babies?
Thank you. Thank you very much, Dr. Zul, for your question. At Empower Mama, what we do is offer the support that grieving parents need, which is the gap that has been in existence for quite a long time, because grieving, especially the loss of a child, is rarely something that many people talk about. So what we do is offer support, and what has proven to be very helpful, as Dr. Chibanda is saying, is the cultural values that we have. Especially as women, we normally love to talk to each other. We listen to each other. You can find a woman just talking to another woman they just met at the store or at the supermarket, and they just start, conversing and engaging together. And that model has been very, very helpful to offer peer support to each other, and of course with professional training to help facilitate the peer support groups. That has really, really helped. And the other thing is we have almost like started another branch just to be able to separate grief and depression. We call that perinatal services. I started that together with my colleague, and that it was just to separate the two things, so that somebody who is grieving don't directly say that or assume they are going through depression, but with support they are able to navigate through that. But then there's these other categories of parents who are also going through many other challenges. It could not be loss, but probably they went through a NICU experience, having a baby in the NICU, or they had a near miss experience, probably like in a case where they almost lost their life when giving birth, and that's traumatic. That can predispose them to mental health challenges if that is not addressed. Young parents who have had even older parents unplanned pregnancies. These are some of the things that predispose people of the reproductive age to some of the mental health challenges, depression being included. And we don't we also include the fathers as well, And so the other model we have been trying to use is to integrate the mental health services into the existing maternal and child health services in our facilities. In 2019, we did a pilot program in one of the facilities in Nairobi, and it was very well received. So what we did was just to introduce mental health specifically for the pregnant and new parents, perinatal, that's what we call it, perinatal mental health services. So, and that was the awareness and the support, because awareness is one thing. And so when people are aware and they need to know, where do I seek support? What do I need to do? So that's model, the integrative model, as opposed to just creating a whole program on its own, really was very, very helpful. So as new mothers are coming in for their antenatal clinic visits, as new parents are bringing their children for immunization, as they're receiving information during the health talks about their how their child is growing and why they need to be coming for vaccinations, for their routine immunizations, and for the pregnant parents, why they need to be doing their tests and attending the antenatal visits and the danger signs to look out for in pregnancy. We also added the mental health awareness on that as well, as a health talk on what signs they need to look out for, what are the resources available. And we encourage the healthcare workers in that facilities to start conversation and to personalize those conversations, because also every situation is different. Every situation is unique. And most of the time, what somebody who's going through a mental health challenge, in this case, let's say depression, what they really need is to be heard, or somebody to just listen, somebody to probe that question and for them to just listen. So peer support and encouraging them to seek professional help and integrating some of these services into primary health care are some of the things that have really helped to mitigate depression. Thank you.
Thank you so very much, Vivian. And I think that, it really resonates with me in the sense that you being an educated woman in Africa, a medical student, was going through depression and not recognizing it, tells you how important it is for us to open up the conversation, because so many of us are in the same boat and we don't recognize it. I just had a conversation with a reporter a few days ago who was saying, how do I know if I'm not depressed? Because people just don't know about it. And so this commission report is so important because it's shedding a lot of light and increasing awareness across the globe. So thank you for that. And thank you for your perspective. I think I would like now finally to move back to Dr. Lukoy Atwali and ask him, how do you think that the Brain and Mind Institute, of which you are an associate director, might be contributing to address the needs or gaps in Africa in general and in Kenya in particular? What is it that you think an institute like ours could be doing to address the issue?
Yeah, thank you, Zul. I think one of the biggest and most important roles of an institute like the Brain and Mind Institute is organizing forums like this to disseminate knowledge, disseminate information to a wide variety of people who wouldn't have an opportunity to engage some of the people on a panel like this. So I think this is an important role for BMI. But before that, another important role for BMI is to generate that information, to generate that knowledge, to do research, figure out solutions for problems that we keep talking about. So that's an important role that we have to play. The Brain and Mind Institute can also influence professional practice through advocacy and through dissemination of best practice. So I think that's another area that we are just starting to play a role, and we are going to continue playing. The Brain and Mind Institute is a great convening space which brings together the experts, the service users, people with lived experience, and brings them together in the same space And when you do things like that, when you bring people with diverse perspectives together to look at a problem, then the solutions you get are more likely to be innovative, are more likely to be appropriate for whatever problem it is that we seek. So I think that great convening power must continue, must be resourced, and must be consistent so that people start looking at these problems in different ways. And finally, with the power of the Brain and Mind Institute, there's an opportunity to influence policy. There's an opportunity to engage lawmakers, to engage policymakers, so that they start using the evidence we generate and collate in order to make better policy that influences practice, influences investment, and influences the lives of our people in very, very, very real ways. So I think there is space for the Brain and Mind Institute to grow and to influence probably similar institutes across the continent that can then collaborate and work together to start coming up with solutions that use the best global evidence and contextualize them in Africa and apply them to among those who need those solutions. Thank you.
Thank you very much, Professor Lukoy. I think we would like to now leave some time open for our participants to be asking questions. And so we are having some questions on the screen now. So one of the questions is, which cultural practices have been eroded and can be useful in prevention and meaningful management of mood disorders? And I think maybe Dixon, you might want to take this question.
Thank you. I think any one of us could take this, but yeah, and it's a great question. Which African cultural practices? One of the things that defined most of Africa is the extended family system that is protective. Across Africa, there are schools of thought that want to dismantle the extended family system. I think we must understand how it can contribute to protecting families and protecting communities, creating cohesion in communities. The second thing that I have observed, not only in Zimbabwe, but also through my travels across Africa, simple cultural practices that you find across Africa, singing, dancing, the expression of our Africanness. In South Africa, it's often referred to as Ubuntu, the African humanity, that is protective. And not only is it protective, it's healing as well. So you find that some of the cultural gatherings that we have and have had for hundreds of years in Africa actually contribute towards that healing process in communities. I'll stop there. Thank you.
Corporate determinants comprise of significant portion of mental ill health. For example, the Center of Disease Control analyzed data from 32 states and discovered that depression and suicides are the highest amongst workers from mining, construction, automotive, entertainment, and agriculture. Why are these corporate determinants of depression not covered comprehensively by the Commission? What is the complement spending per capita to avert depression in Africa globally? And which economic sectors should be taxed to improve spending to avert depression, considering the current underinvestment in the context? So open it up to anyone, but maybe Dr. Sabin, maybe Lukoy.
I would just say quickly that I think this is a really interesting point and points to the need to really understand across many different sectors of society where and how people may be suffering and where they need to receive their care. So I do think it's a point that should be definitely followed up on. I think, in terms of the Commission, it's talking a bit more, generally across the whole, issue of depression. And I must say, as a Lancet editor, unfortunately, the poor commissioners don't get as many words as they would like to cover all their points. We often have to cut back, and we're not able to include every point we would wish to. But I do really want to acknowledge the importance of this question and the need to look into it further. Thanks.
Yeah, and I might just add that thinking about corporate environments, they ought to be thought of as part of the social environment that people find themselves in, and social determinants of mental health are absolutely important part. So people need to work, but then the environment in which they work shouldn't be an environment that then diminishes their mental health. It should be an environment that helps them to feel productive, to feel like they're an important part of the human race, and this is good for your mental health. So if the workplace is structured in such a way that it doesn't make you feel productive, but makes you feel like a robot, or makes you feel like something less than human, then it starts becoming destructive of your mental health. And many of the sectors that have been listed here in the US, if you ask me, are set up so that people go in almost like automatons, doing routine things, and then leaving without feeling as if they're contributing to something greater than themselves. And that is a problem. And so as we think about social determinants, we should think about workplace mental health and structuring workplaces so that they are supportive of mental health rather than diminishing people's mental health and making them feel less than human. The second part of this question talked about spending and what we need to do about this. If you looked at many African budgets, less than 1% in any good budget is being spent on mental health in Africa. And I think we can do better. And we can spend mental health dollars in different sectors of the economy, in education, in health, in industry, in various sectors. We can spend mental health dollars. Where do we get these mental health dollars? I think there are multiple potential sources, and we have had a discussion around taxing certain things that are detrimental to mental health but are allowable in society. For instance, there's substance use. We could tax alcohol, and we can tax it as much as we want because nobody needs alcohol to survive. And when people use it, then if some of the dollars being spent on alcohol can be channeled towards mental health, they will help reduce the mental health burden due to alcohol use, but also help prevent a lot of these problems. The same with tobacco, the same with sugar, if you ask me, the same with whatever we tax people who drive dangerously and so on. So if we looked around and looked at some of the things that have a negative impact on mental health and taxed those behaviors and spent that money in mental health promotion and prevention, we will start chipping away at future mental health problems. And then whatever remains, we can spend it on treatment for those who have already suffered the detriments of these behaviors. So I think that is an important way of looking at this issue. Thank you.
Thank you very much. I think that the person who was asking the question, Dr. Cyprian from the Brain and Mind Institute, I think would really love your answer, because that's exactly what he is proposing to do, is to tax different sectors to fill the gap that's financially needed. Maybe we'll take one more final question. Can any brain scan guide treatment for depression? Maybe Dr. Javed?
Well, of course, we are still in the process of finding a particular test that can determine, as we are having the specific tests and tools for many other medical disorders. But we have to keep one thing in mind, that depression is a multifactorial illness. There are genetic factors, there are environmental factors, there are chemical factors, there are so many other psychosocial factors. So a test can only detect some abnormality in one area, but won't be able to detect in many areas that are either precipitating or perpetuating depression or maintaining or sustaining the depressive illness. Of course, there has been a lot of advancement in medicine. For example, in areas of genetics, we are now reaching to a stage that where we will be able to find some genes that are responsible for an illness, but also that can give us and guide us about the appropriate treatment for that particular illness. So just a sort of a short answer, unfortunately, there is no specific test, but there are many pathways that can determine, that can tell us about the diagnosis of depression. The only biggest test as a clinician, what I can say, listen to the patient, listen to the patient, and listen to the patient.
Well said. Thank you very much. All right, so we're coming towards the end of our webinar. What I would like to do is to give each one of you a 30-second opportunity to do your final observations and comments. So Dr. Sabin, why don't you start?
Thank you very much. Well, again, it's really been an honor to be able to participate with all of you and to listen to all of you today and what's been shared, including on the questions. There were some themes that really came out for me, and one is on social support, which costs nothing and is culturally appropriate. There's so much that can be done to just support people in their communities. And to, I think the other point is just how strong shame can be, how strong stigma can be. So I'm starting to think about 4 S's: shame, stigma, and social support, and how we need to reduce the two and increase the other. And just from the Lancet perspective, to share that this is a living commission, and we hope that this work and this conversation will continue. And we look forward to that very much, and good things coming from the African continent. Thank you so much.
Thank you. Dr. Javed.
Well, I think this has been really a sort of a very stimulating experience. Listening to the panelists, answering the questions, being a part of the agenda, I think we are achieving our goals. And our goal is to help, support, and to strengthen the resources of our patients and their families. Depression, I can only say one thing, is treatable, it is detectable, it is manageable. So don't die in suffering. Just try to find out how can we cope and how can we treat and manage this problem. We will certainly be successful in reducing the burden of depression with all these reports, discussions, and webinars. And thanks to Lancet, thanks to you, thanks to the Aga Khan University and all the organizers for supporting the cause of mental health.
Thank you very much. Dr. Chimbanda, final comment.
Thank you. We need to think outside the box. We need to immerse ourselves in African culture, African values, but at the same time, we need to use rigorous evidence-based methods and ways of actually testing some of these unique innovations which are culturally rooted. Thank you.
Thank you very much. Maybe Vivian.
Thank you very much. It's been a great honor to be in this esteemed panel today, and thank you very much for everybody who joined in. My parting shot will be, it is important for us to change our attitudes towards depression and other mental health conditions. Given my own experience, that is coming out very clear that we need to change some of our attitudes and perception that depression is a common condition. It's not a white people thing, or educated people cannot get it, or rich people cannot get it. but we need to change some of those perceptions. We need to educate ourselves on what it is. We need to know where to seek help and support, because seeking help early improves the chances of prevention. And like we've heard from Dr. Afzal, recovery is possible. I'm a living testimony of that. Recovery is possible. Thank you.
Fantastic. Thank you so much. And Professor Lukoe.
Thank you. Thank you very much. I've also enjoyed being part of this panel, and I think we are all on the cusp of something important and something great as we have these conversations. 1 in 6 humans live in Africa. The other 2 are in China and India. And millions of others living in other parts of the world have a recent and direct link to the African continent. And of course, everybody else has a remote connection to Africa, where we all came from. I believe that innovative interventions in a lot of the problems that we humans have will be found back where we came from, on this continent. And we have to keep looking here, keep investing here, if we want solutions that will benefit all parts of the world. As we do this, I think we have to focus, as we said, that Africans are young. Half of the continent is made up of young people under the age of 19. And we are going to benefit the future a lot more if we focus on this population and figure out ways of preventing them from getting depression and from getting other mental illnesses. So if we invest a lot in that segment, then there will be future, there's future harvests to reap if we start now and start early. Thank you very much.
Thank you, Professor Lukoe. Wise words, and I think you're resonating with what Dr. Louis Leakey was saying about Africa. So I think you're very right. Now, I would just like to say how stimulating it was for me and for our participants, global participants that have been joining in this conversation. And so I wanted to thank the panelists for a very stimulating and very exciting and very frank and open discussion about depression and what to do about it. I'm really so delighted that we're finally beginning to open up this dialogue so fully so that we can, as Dr. Lukoe was saying, prevent our young generation from facing the same consequences we did. We want to do better for our youngsters. And I think it is upon us to kind of chart the path for them so that they have a better life and a productive life. Because as I said at the outset, Africa is at the verge of having a huge impact globally, and we want to make sure it's a smooth one and a very impactful one. So thank you all. I'm now going to turn it over to Kendi, who will tell you about what are some of the next events coming up on our horizon at the Brain and Mind Institute.
Thank you so much, Zul, and I concur what a meaningful webinar session, lots of learning. In terms of what's next from the Brain and Mind Institute, okay, first, please share your feedback with us. Your feedback really informs how we engage with you, the community, how better we can do that, and what are the gaps that need to be addressed. Secondly, we'll be having a conference in November 2023, the BMI conference on mental health and neuroscience. Please look out for that. It will be a pleasure to host you again and really to engage in intellectual discourse that informs practice and policy within our different communities.